Fantastic. So there will be one band where this bladder will be adherent, and below that it will all be free. अंदर आ जाओ बच्चे. So you just have to find that plane. And can you see the uterine there?
Yes, ma'am.
So we'll just start with this and cut this. पेश अपना हाथ अपने पास रखो. Bladder is really densely adherent. अगर bladder खुलता भी तो स्टिच कर देंगे, इसकी कोई बात नहीं है, लेकिन अच्छे से डिसेक्ट करेंगे तो बेटर है. पकड़ो नीचे की तरफ ऐसे. शाबाश. Here, don't move from here, all right? I can see very well. थोड़ा ग्लेयर कम कर पूजा. ब्राइटनेस थोड़ी कम करो या लाइट थोड़ी कम करो. इस जूम लाइट, हाँ बस थोड़ी सी बढ़ा दे और बस बस अंदर आ. ब्लैडर इज वेरी बैडली adherent here. Very direct karo. Yeah, this isthmocele very this nowadays we are seeing a lot of isthmocele, and the reason for that is people closing in a single layer, not. Pooja, please centralize the part and turn the light cable little to the right, beta. I'm going in the avascular paravesical space, because here the bladder is like really densely adherent. So I don't want to injure the bladder in the first case. Pura right mein light cable turn karo. Right. Yes. So we'll see the obliterated umbilical vessels and come in this avascular space, which is the paravesical space, which is the medial paravesical space. Come in here and see where the bladder is going. Okay, पीछे आ जाइए थोड़ा सा, and then lift this whole thing up, and then you will get your plane. कैथेटर है ना अंदर भाई? Pooja, don't move, please. I can see very well. The minute you move, my orientation goes. So doing a good cesarean is something which everybody should know. Do a 2-layer closure, close one of the peritoneum. Don't have this hurry of doing 17-minute cesareans, residency competitions, because the patient pays a very heavy price for it.
Hello? First you try.
बिल्कुल ही चिपका हुआ है. एक्चुअली यहाँ पे ना ये नहीं है, यूट्राइन मसल नहीं है, इस्टमोसील है ना, इसीलिए वो बीच का प्लेन मुश्किल से मिल रहा है. अब ठीक है. अब ये क्रॉस दैट इस्टमोसील एरिया ना, नाउ द ब्लैडर विल गो डाउन नाइसली. Just this istomoceal area which is horrible. Can you see that istomoceal area? Is the audience with me? See, this is the istomoceal area. The minute you cross it, then the bladder will go down nicely. Can you understand that?
रिकॉर्डिंग दिखाना।
हाँ रिकॉर्डिंग रहेगा। अब ऐसे हम लाइव कर दे रहे हैं अभी।
And these are the bands to identify the istomosil. Can you see this band which is come here?
मोबाइल पे मिलेगा।
So in case you don't know where exactly you have to cut and how much you have to cut the istomosil, those bands help you. These two lateral bands. Okay? अब ऐसा पकड़ो, शाबाश। बाइपोलर डालो बीच में। ओ भाई, बाइपोलर डाल दे। जल्दी डाल, जल्दी डाल। मेरे को ब्लड अच्छा नहीं लगता। So now we are taking the uterine. पूजा, पूजा, अंदर आओ। लाइट के थोड़ा लेफ्ट में टर्न करो। हाँ। Smoke out करो। कुछ नहीं करो। That's the vein. थोड़ा सा स्मोक आउट कर देंगे प्लीज। Is the vision clear there? Is the vision clear there, नीलमा? स्मोक आउट करते रहो ना भाई। सक्शन दे दो एक बारी। पोट पकड़ो सेंटर वाला। सक्शन डालो, सक्शन ऑन कर दीजिए भाई। सेंटर में दिखा दो। सक्शन का प्रेशर थोड़ा बढ़ा दीजिए प्लीज। प्लीज थोड़ा प्रेशर बढ़ा दीजिए और प्लीज। पोट पकड़िए। टूथब्रश में डालिए या बाइपोलर डाल दीजिए। यू भी देयर, यू कॉन्फिडेंट। बाइपोलर डाल दीजिए, शाबाश। You can see the planes are really bad here because the cesareans were good that she decided to do a hysterectomy. Otherwise, this poor girl would have suffered forever. Smoke out करते रहिए प्लीज। अभी नीचे से वॉल्ट खुल जाएगा, सारी स्मोक निकल आएगी। So we do one side completely, and why we do this is that we know that the right-sided uterine artery is the time when you're going to take the right side uterine artery. At that time you will have, yeah, foot de do na please. That is the time you have maximum ureteric injuries while taking the right uterine. So if you totally, if in this sunrise method, you'll have the uterus hanging on the right uterine. Word close कीजिए. You could use a menstrual cup to close the word, or you could just use your simply your hand to close the cup. एक टूथब्रश पर डाल दीजिए सेंटर में, पोट पकड़िए, टूथब्रश पर डालिए, शाबाश। नीचे से गरीब गैस रिलीज करा। This is the opposite side uterosacral now what I'm taking. Can you appreciate that?
Yeah, we can.
आगे दिखा दो, कैमरा सीधा पकड़ो। Is the audience there with me? No questions?
Yeah.
But कोई question ही नहीं पूछ रहा, कोई कुछ नहीं पूछ रहा।
Very nice description. So,
A very nice dissection, no questions, no doubts. Very august audience, everybody knows everything, that's good. So here I'm going till the other side, can you see that? This is that much of bladder which is left, I'm taking that completely, I've gone till the right side. Okay, थोड़ा सा bladder यहाँ ये वे में आएगा तो उसको काट दो, ठीक है? बस हो गया. So now I've taken this completely. Nothing is done on the left side, on the right side, and left side is complete. This is the sunrise method. Can you see that?
Yes.
Now,
One question, ma'am.
very good.
How is the pneumoperitoneum maintained after you have opened the wall?
Somebody show my beautiful assistant's hand. See what she's doing. She's just using it like a policeman. बाहर का कैमरा दिखा दीजिए, कैमरा पर्सन. नहीं यार, इधर दिखाओ ना, इधर इधर इस लड़की का हाथ दिखाओ. Push, 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 Tanisha, push. Okay. So now, again we are taking this side tube. Can you see Sachi's hand?
Oh yes, yes, ma'am.
So all she is doing is she's just blocking the vulva with her hand. That much is more than enough. Bipolar de dijiye please. Center में. Port पकड़िए. पकड़ा? Very good. Sunil is a fantastic assistant, ma'am. मैं उसको चोरी करने वाली हूँ आपसे. Headache खत्म हो. प्रॉब्लम है ये फुट का, थोड़ा फुट आगे कर दीजिए बाइपोलर का और उसका ये फुट मेरे हाँ पोट पीछे कर बेटा सुनील पोट पीछे कर. Ovaries are looking healthy, there is no family history of any cancers, nothing. Left foot पीछे कर सुनील. And like I said, Allen is a wonderful instrument and both the harmonic and the cautery. Tanisha, you okay? Switch your hold and give it to her. Oh God. हाँ दोनों एक साथ चाहिए मेरे को दोनों इंस्ट्रूमेंट्स यूज करने की आदत है. See, this is your shearer. So you can actually do the hysterectomy totally with the shearer also. You don't need harmonic. But since I have the luxury of getting both, I'm using both. Smoke out करो नीचे से सूची. कर दे और बेटा. See now I'm just cutting with the shearer. Shearer के साथ you just have to use smaller bites and a cutting current. Can you see that?
Yes.
So now you're done with this. Port center port पकड़ो. बस एक बार हाथ दिखाओ मुझे. ऐसा पकड़ो. शाबाश. नीचे से स्मोक आउट करो. अभी हिस्टेरेक्टमी में कुछ बचा नहीं है. तो ग्रास का दे दो ये पोर्ट में. तो ग्रास करो लेफ्ट पोर्ट में. शाबाश. इसको रेट्रोवर्ट करो और नीचे और नीचे और नीचे. शाबाश. ऐसे ही रहना. स्मोक आउट कर दे सूची. बस. So little bit of that isthmosal part is there. I'm just cutting that. इसके नीचे काटते ही you'll get the uterine vessel, part of the round ligament, and now here you can see the posterior leaf of the broad ligament. So again you take the posterior leaf of the broad ligament, and ON.
I have one question.
Yeah, please go ahead.
What is the benefit of doing one-sided hole and then other-sided?
Yeah, the benefit is that in literature shows that the maximum number of injuries to the ureter are on the right side, and they are while taking the right uterine vessel. Okay, so when you do this, you can see my entire uterus is dissected. My entire, from this side and that side, the entire uterus is hanging on the right uterine. Do you understand? So in case I have to just simply take the uterine vessel, अगर ब्लीड करती है यूट्राइन वेसल, तो मैं यूरेटर इंजरी, यूरेटर को मैंने पहले लैटरलाइज कर दिया, नीचे से भी आगे से भी, और राइट यूट्राइन इफ इट ब्लीड्स आल्सो आई गो लैटरल आल्सो. आई नो देयर इज नथिंग एल्स बिकॉज आई हैव डिसेक्टेड जस्ट अबाउट एवरीथिंग एल्स. कैन यू अंडरस्टैंड? So that is the advantage with this. The ureteric injuries are less.
Ma'am, one question.
Yes, please.
What we have opened on the left side, but still some part of bladder is attached on the right.
Yeah, that we'll do while we are going down. You don't have to over dissect the bladder. Only as much as needed. Okay?
Okay.
So you can see here, if I go and dissect this, there's no point. I'm going to go on this line. Do you understand? So why should I dissect that bladder?
Oh, we are not going to dissect that part then.
No, there's no need for it. Central में ज़्यादा dissect करो, lateral में कम. And you have to do the ascending uterine. Now, whenever in doubt on where to take your uterine, look at your uterosacral. It's पूजा नीचे डाल. ये uterosacral यहाँ काटा है. At this level, you should be taking your uterine. Do you understand? Now, why you do that is, now I'm just going to release the myoma screw and show you something. ये पकड़ो. See, uterine has got the transverse part and the ascending part. Okay. Now with the myoma screw, when I stretch, this transverse part looks like ascending, and the ureter is only 1 point. I'll just show you the ureter. Only 1.5 centimeter away here. Can you see? So it is very close. This is the ureter, very close to the transverse part. Understood? Of the uterine. Can you see that? This is the transverse part. Ureter is right here. So in case I take it here, my chances of lateral spread and injury to the ureter increase. Whereas if I take it here, I'm a safe distance away from the ureter. Understood?
Yes, ma'am.
So now when I take it here, when I'm stretching it, मुझे खुद confusion होगा कि मेरा transverse part कहाँ है और vertical part कहाँ है. So how do I allay that anxiety? By seeing my uterosacral. At the level of uterosacral, I will take the uterine. So then the chances of, this is all because we are a teaching institute. क्या करूँ मैं? अच्छा, change करते रहने वाले. वाह. So we get a lot of fellows and we need to do things जिससे they can also do surgery, and not only we. And we can comfortably sit in the surgeon's room. So they can do it if it's a standardized procedure. Everybody at Sunrise will do the hysterectomy the same way.
In books we usually read that direct trocar injury, the primary port injury, trocar injury is not safe.
Sorry. Where did you read this?
Mostly.
Maybe, where did you read this?
Used to,
No, where? Today is the world of evidence-based medicine. And you cannot say, I saw this and she saw this and my teacher saw this. You have to see what are the randomized controlled trials saying. Look at the RCOG Green Top Guidelines. RCOG Green Top Guidelines are also telling you direct trocar, Veries, Hassans all have the same rate of injuries. And what is your fear? Your fear is you injure the bowel, right? Yeah, mobile bowel is very difficult to injure. Try to hold a bowel and injure it. Why do you lift the abdomen when you are putting the trocar? Has anybody thought of that? You are not doing it to prevent bowel injury. You are doing it to prevent retroperitoneal injury so that you don't damage the aorta. Understood? So you're just keeping a distance from the outer. Bowel is adherent on the anterior abdominal wall. Even if you lift the anterior abdominal wall, how will you prevent injury? तो अगर इंजर होना है तो होएगा ही, जो मर्जी कर लो. सक्शन दो. सेंटर पोर्ट पकड़ो. सक्शन का प्रेशर बढ़ा दे भाई प्लीज. यार प्लीज थोड़ा प्रेशर बढ़ा दे. बहुत टाइम पास हो रहा है. Hysterectomy is a 20-minute procedure. Spongial holder. We took a little extra time today because of this bladder resection. Otherwise, it's and because we're not used to this OT. But for the next case, I promise you, we'll go faster. Number 1, Michael, cutting needle. या रिवर्स कटिंग कुछ भी चलेगा. एक्सपांजन होल्डर रेडी करो सुची. ये सक्शन बहुत स्लो हो रहा है. पीछे आ जाओ भाई.
लाइव तो कर दिया एक बार ऑडियंस का भी लाइव करा देना.
पोट पकड़ो सुची. पकड़. बुलडॉग दो. बुलडॉग वल्सलम. बुलडॉग वल्सलम. ये स्पंज होल्डर है. मुझे वल्सलम चाहिए या बुलडॉग जो भी बोलते. 15 सेंटीमीटर. फिंगर सेपरेट करो. पूरा मत खोलो. हाँ आप दिखाओ. हाथ छोड़ो मेरा. रुक जाओ. आगे में नीचे. यार बुलडॉग, ये बुलडॉग अच्छा देना ना. ये अच्छा है. कोई ना, हो गया केस. स्पंज ऑन होल्डर है. स्पंज ऑन स्टिक. ऐसा नहीं. ये नहीं यार. एक स्पंज या मॉप दे दो. कुछ दे दो. वापस झाड़ू मार. कहीं से ब्लीडिंग आ रही है. यूट्राइन ब्लीड करिए. एक बार रुको 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 रुको. वॉल क्लोज करो. वॉल क्लोज करो फटाफट. ओके कोई बात नहीं. कुछ नहीं हुआ. वो यूट्रस निकालते निकालते हुए. कोई बात नहीं. यू कैन ईदर क्लिप दिस. ऐसा बहुत बार ही होता है. सबके साथ होता है. और यू हैव टू डू इज यूज अ लेगा क्लिप. तो तुम खोलना चाहिए ना. यूट्राइन ब्लीड कर रही है मैडम. कब? If there is a vessel you should be scared of, it should be ovarian, not the uterine. Uterine is your friend. It's the 5th branch of the aorta. Tortuous vessel. It will give you enough time to come and hold it. So see it properly and then take it. Once you've held a bleeder, even if you've done an aortic bleeding, you can control it. It's only when you don't see then you have issues. Port पकड़ो. Allen डालो सेंटर में. जल्दी जल्दी जल्दी. Allen. हार्मोनिक. हाथ छोड़ो मेरा. छोड़ो ना. स्मोक करो. सक्शन दो. अरे पोस्ट तेरा बाहर निकल रहा है बड़ी बड़ी. राइट आप दे दीजिए. राइट साइड आप दे देंगे प्लीज. So there are certain tricks. Because of my height, I find it very difficult to do contralateral suturing or anything. So I have a little few tricks which we use. बोल मत करो. राइट साइड आप दे दीजिए प्लीज भाई साहब. थोड़ा जल्दी कर दीजिए. राइट आप. Any technician on the floor who knows about the floor? ये क्या कर रहे हैं आप? ये मेरे बाजू आएगा पेशेंट. आप हेल्प कर दो प्लीज सुनील. और पूरा और करो बस खलास. द्रौपदी की साड़ी में काटी है तो नहीं. सेंटर में टूट दो, लेफ्ट में मेरी लाइन दो. एनी क्वेश्चंस? डॉक्टर नीलू आपके पास ऑडियंस है ना? ये पकड़ो, इधर आओ तनीषा. हाउ मेनी पीपल आर देयर इन द हॉल? मुझे लग रहा है साइलेंस है, आप और मैं खाली है मैम.
हॉल इज फुल. हॉल इज फुल. हम एक यहाँ से रिले तो नहीं कर सकते हैं, वहाँ टीवी नहीं है.
कोई आवाज ही नहीं कर रहा
है ना?
इतनी औरतें साथ में और एक भी आवाज नहीं.
मैंने एकदम पिन ऑफ साइलेंस से सब सीरियसली वॉच कर रहे हैं हर स्टेप्स को.
चलो अंदर आओ.
मैडम व्हाट लेंथ ऑफ suture is the ideal?
15 centimeter.
15. And which suture material you are
I'm
using?
using Vicryl. You could use barb, you could use rapid, you could use whatever, because the wall healing will happen within 6 weeks, so you don't need anything which is more than 6 weeks. ये अटक रखे हुए भाई. So here now I'm going to show you something which is a little different. You can see the POD is deep still, and she's still only 40, so we don't want a wall prolapse to happen. So what we will be doing is we'll be showing you a Moskowitz, since already Tanisha has cut the suture so long. ये इंस्ट्रूमेंट टोकार में अटक क्यों रहा है? हाँ, बड़ा है क्या ये? 5.5 इंस्ट्रूमेंट है क्या? पूछा एक और लूप लेने दे बेटा. See, we've done a few tricks here when we came. Suppose your height, like or average female height, like my height is only 5 feet 4 inches. So laparoscopy can become very difficult if your table is not proper. So in that case, in an ortho table, you can put the head end on the foot and foot end on the head and get a better length. बस. दोनों पोर्ट में अटक रहे हैं. थोड़ा इंस्ट्रूमेंट बड़ा है लगता है ये वाला हैकर वाला. ज्यादा मत खींचो, ब्लैडर कटेगा. So sometimes you find that the POD is deep, or the patient is, somehow going to have a little more time. बंद करो अभी वॉल्ट मेरे को नॉट मारने दो. So much of raw surface is because we've done so much of lateral dissection. क्या बेटा? Left side में ना? You try, वो भी check करेगा. Don't worry, I can understand.
So good morning, Nikita.
Good morning.
Myself Dr. Vinita Singh.
Hi, Dr. Vinita. How are you?
Namaste, absolutely fine here. So it's such a nice surgery we are seeing here live. So can you tell me if the patient is very obese, what should be the support positioning that is very important?
Ma'am, try to avoid the pannus. You know, when the patient is very obese, usually the pannus will be there. And that pannus is the one which obstructs your, this thing, movement of the hand. So go below the pannus, clean that area properly, and then you'll not have any issues. That pannus is the most important.
That is important. Pannus is important.
And clean the pannus for 3 days before. And of course, more than me, the challenge is for the anesthetist in that case, because giving the anesthesia in obese patients has its own logistic issues.
So you can remember the panel discussion which we had.
Yeah.
I was there.
Oh yes. ये पकड़ो, अब हाथ हटा दो, सक्शन दे दो, सक्शन दो. We are getting a lot of obese, previous cesareans, all these nowadays, no?
Yeah, and even
Price.
fibroid.
तो ठीक है मैम. Endometriosis. Endometriosis is a new kid on the block. Adenomyosis, endometriosis, and it's a horrible disease. And what we should be telling our patients are certain preventive tips, which are don't drink water in EDCs. EDCs are endocrine disruptors, and these EDCs are causing all the havoc and endometriosis, adenomyosis. So what now I will show you is, I'll show you how we do a Moskowitz laparoscopically. क्या बंद कर, अभी सक्शन बंद कर, 2 मिनट बाद वापस चाहिए होगी. राइट पोर्ट बाहर करो सुची, बस. So in the Moskowitz, you can see the uterosacral here when I'm tugging on it. Yeah, so go inside, Pooja. Take the uterosacral. या मेरा पोर्ट अटक रहा है इसमें, डाल दे अंदर, डाल पोर्ट. That is the reason. अच्छा, ठीक है. So what we do is, we take the anterior rectal wall, the peritoneum and the anterior rectal wall, so that this gets supported. Can you understand that? Is the audience with me?
Yes.
So this is to prevent future wall prolapse. You remember your Beckons and yeah, so exactly same thing we are doing laparoscopically now. है ना? So now you can see that POD which was deep is become normal POD. इसको थोड़ा ढीला करो, बस. अभी पकड़ो, बस. ठीक है? बिल्कुल. ये यहाँ पे एक ब्लीडर लग रहा है बच्चों. एक बार यहाँ पे मुझे सक्शन डाल के दो. कोट पकड़ो राइट वाला, वो बाद में बांध दूंगी, पहले मुझे ब्लीडर पकड़ने दो. सक्शन. यार सक्शन थोड़ा बढ़ा दे यार, बहुत टाइम पास हो रहा है उसके साथ. फुल कर दे. See, now this area was a little bleeding. If I just hold it with my grasper, just hold it for 5 minutes, then also it will stop. So you don't have to coagulate each time, you just have to watch it for 5 minutes. Can you see that? You just hold it for 5 minutes, it will block, and that's it. See, now you don't need to do anything. अगर होगा तो एक बस मार देंगे. ठीक है? नीडल होल्डर डालो.
I think little bit oozing is there, Nikita.
Yeah, we'll take it later. I'll just tie this knot and watch it. अगर बंद होता है कि नहीं होता है. Because I've just held it. It's all very close to my bladder. So I'm not very comfortable unnecessarily taking it like that. So Dr. Neelu and me will be starting our regular programs here. I'll be coming every month. So whichever surgeries or anything you would like to come and be, please inform Dr. Neelu. Because the setup is amazing here, the cameras are good, the assistants are good, hand instruments are wonderful. So we can do just about everything here. Priyanka. हाँ नहीं कुछ नहीं अभी तेरे को देखने वापस मिला देते इमेजिन क्यों भाई करना तो सिस्टोस्कोप ही कर ऐसे जरूरत नहीं है ब्लैडर एकदम सेफ है मैथिली फ्लू से भर दीजिए बंद नहीं हो रहा है छोटे लग रहा हाथ एक रास्ता बंद नहीं हो रहा दूसरा नाच में नहीं दूसरा कोई दे देना बेटा क्या हो गया
हम तो आज धन्य हो गए हम तो पहले ही बोले आज के दिन एकदम आप लोगों का
Striker के साथ there is only one issue which we have in a striker camera that everything appears a little more red. Okay, now we can see if it is still bleeding. How you will see is not by touching that area, by seeing if it's trickling down. Suction डालो सेंटर में फटाफट और suction का pressure maximum सेंटर में ये पकड़ो ना तनिषा कुछ नहीं है that's just looking wet. Okay, so that is good hemostasis. I'm extremely satisfied. There is no issue and I have got a good uterosacral suspension. Also यार suction का pressure बढ़ा दे भाई please. ठीक है हार्मोनिक में जल्दी से आप छोड़ दो ना मेरा हाथ So thank you very much. I will be coming to the hall. Okay, and we by the time the next case is induced, we will do a lecture on pelvic anatomy. Sorry, you निकाल दो please.
इसीलिए फिर आपसे नहीं बात
बोला था कि
फाइनल नहीं वो जाकर प्रधानमंत्री कार्यालय से जान होगा हम लोग भी आज नहीं आने वाले थे 25 ही का सारा कैंप और स्पेशलिटी
टाटा कैंसिल, टाटा नहीं है वो। और आप काफी नहीं लॉ
It's always a pleasure to be here.
Coming together is a living the progress. Namaskar and a very good morning to all of you. I am Dr. Kulhavaskar Patni.
And I am Dr. Shama Kausturi. We are privileged to welcome you all on the behalf of organizing committee of one-day CME cum live laparoscopic workshop at Astalok Hospital, Patna.
Sincerely welcome and thank you all for making yourself available in this Sunday morning. We would now start with the keynote address session. Today we have many more cases for the OT. First of all, we are thankful to Dr. Neelu Madam for the organizing such type of a workshop once in a year. Thank you Dr. Neelu ma'am for organizing this type of workshop. डॉक्टर नीलू मैम के इस तरह के एम्बिशियस थॉट से हमें ये पता चलता है कि
success is not the key to happiness. Happiness is key to success. If you love what you are doing, you will be successful.
now, it will be my pleasure to invite the director of Asthalok Hospital, our blooming rose, Dr. Neelu Prasad Madam. Please come on this stage and say a few words for this workshop, and our master trainer, Dr. Nikita Pradhan Madam. Thank you, ma'am.
Very good morning to all of you, ladies and gentlemen, esteemed guests and fellow participants. Thank you all for being with us today. A warm welcome to honorable guest, our master trainer, guest faculty, Dr. Nikita Pradhan, our chief guest, Anita Singh ma'am, our teacher and well-known consultant partner, and together with Dr. Usha Kumari ma'am, the principal, Nalanda Medical College, and together with our most respected senior guest of honor, Abharani ma'am, and Vinita ma'am, Jalil Rahman ma'am, or the great practitioner and consultant from all over the part of the Bihar, like Madhu ma'am or Poonam ma'am, and there are so many list of the doctors that it is very difficult for me to name everyone. So, together with all our esteemed dignitaries, my dear colleagues and lovely juniors, in this seminar, we embark on a journey of knowledge and grab the long learning curve of laparoscopy. Your presence signifies a commitment to knowledge and collaboration. Together, let us explore ideas, share insights, and inspire one another to drive positive changes in our respective fields. As we engage in discussion and learn from each other, may this seminar be a catalyst for innovation and growth. Let us exchange of ideas, empower us to make a meaningful contribution to our communities and progress future in health care. Your today's presence is a testament to our commitment to knowledge enhancement of skill and pursuit of excellence. We are privileged to have such distinguished fellows in the amidst and showing their keen interest in expertise themselves in the field that will definitely bring a wealth of experience. As we gather here, let us embrace the opportunity to share insight, engage a meaningful discussion, and foster connection that transcend the boundaries of all the respective domains. The exchange of ideas and expertise during this seminar promises to be a catalyst for innovation and progress. I extend my heartfelt gratitude to each one of you for gracing this occasion with your presence. May our collective effort contribute to a rich tapestry of learning and skill enhancement. Now, let the seminar unfold to a memorable and enlightening experience to all of us. Thank you all of you. Thank you.
Thank you,
हाँ,
Dr.
बोलिए।
Neelu ma'am. Now I would like to call Dr. Nikita ma'am, our master trainer. Ma'am, please
अच्छा
welcome.
बैठिए ना अभी, आज देख लेगी, बैठिए। ब्लड टेस्ट हो गया है ना? हाँ ठीक, जांच होने दीजिए। दिखा देंगे, काहे हड़बड़ा रहे हैं? ठीक है, बैठिए ना।
So, thank you very much for having me here, Dr. Neelu and the entire team of ASCA. Look, it's always a pleasure to be here. Without much ado, we will be starting with the academic part. What we plan today is, because we don't want to waste the time of the audience, we will be doing, by the time the case is getting induced, we will do one lecture and then case is getting induced simultaneously. So, certain important topics which I personally feel when I get my fellows, because we have 6 months fellowship program, their understanding of anatomy, which is vital, is lacking. And so, how do we understand laparoscopic anatomy? How do we go about it is something which I would like to highlight today. I will also want to talk on 2 other topics which are our specialities. And if any suggestion for topic, I can talk on any topic. We have lots of lectures prepared. But the topics I suggested for today was pelvic anatomy. Second is endometriosis and adenomyosis, which has become the epic thing of the century. And third is Mullerian anomalies and congenital anomalies, which people don't understand. And cancers we can do if we have time, because we do a lot of C endometrium, C cervix, everything also. So depending on the time, we will proceed. And this is an open house, and I would really like for the audience to be interactive and talk in between and ask anything in between. Okay, don't let it be a one-way story. So, क्या ये connection ठीक कर दो भाई? So, what are the anatomy of the pelvic spaces? आपको आ रही है audio vision? So the anatomy of the pelvic spaces is extremely important. We know that the spaces, you have the central spaces and the lateral spaces. And all the spaces are extremely important for you to become a good laparoscopic surgeon. So in the central spaces, you have the space of Retzius, you have the psychovaginal space, you have the rectovaginal space, you have the retrorectal space. All these spaces are extremely important, and the lateral spaces, you will have the Platzko, Okabayashi, Paravesical, all these spaces. I'm not going to talk about it in the textbook manner, I'm going to show you. So how do we start and how do we understand? Because many times when I'm telling the fellows also कि ये देखो ये है, they'll start correlating and saying, oh but letter पे ऐसा है. See what is their life. Okay. So how do we start our dissection? This is a case of CA cervix that I'm doing. And what I'm doing is I'm opening the space between the IP and the round and going, so this is the lateral window or retroperitoneum, which I'm opening and going between the round and the IP. So when you go in here in this space, it's a completely avascular space. You cut the round ligament as lateral as possible, and herein you go down and you will find, you can see the obliterated umbilical there, and what you will find lateral to the obliterated umbilical is the lateral paravesical space. So the 2 lateral spaces anteriorly will be the medial and the lateral paravesical space. So here, the first structure you will see will be the obturator. So you can go as low as you want. You can see the obturator, vein, artery, nerve, van, as we studied in our childhood. And this is how you will see in the lateral paravesical space. So this, again, you can see now, you have the obliterated umbilical artery in the center. Between the ureter and the obliterated umbilical, over here, you can see the only structure which is going transverse is the uterine artery. Tortuous, 4th branch of the aorta, nothing to be worried about this vessel. Lateral to the ureter is the Latzko space. Medial, Latzko's pararectal space. Medial to the ureter is the Okabayashi space between the peritoneum and the ureter. So this is the ureter. Medial to it will be the Okabayashi space. Lateral to it will be the Latzko space. These are the pararectal spaces. And when I'm dissecting this, now I'm dissecting the medial pararectal space, and I'm going down, and when you go down deeper, you will find all the pelvic splanchnic nerves, and here in a second will pop the inferior hypogastric nerve. Can you see the nerve there? This is the nerve which I'm holding and tugging. That is the inferior hypogastric nerve. Now, don't get confused because still people have a lot of confusion कि endometriosis में ऐसे नहीं दिखाया था. That is because they cut this peritoneum. ठीक है? So if I cut this peritoneum, then you will see uterosacral there. So between the uterosacral and that, you will be seeing it. Request you all to please keep your phones on silent. So here now I'm going to the Latzko's pararectal space, and so here this is the obliterated umbilical vessel which I'm using as a marker. Anteriorly now I'm going to the medial paravesical space. Can you see this tissue? This tissue, when you see, you should know it is the bladder. It has got a different texture, different mobility, and between the obliterated umbilical and the bladder, this place is completely avascular, and that is the place I used just now to dissect my bladder also. So, knowledge of anatomy, that there is nothing there, no vessel, nothing between the bladder and the obliterated umbilical. You can create that space, and utilization is for all your endometriosis, for all your bladder dissections, that needs to be utilized. Now, this is the rectovaginal space, and between the two uterosacrals, you open this space. We use this a lot now, even more than we were using earlier, and there are two layers of denovelous fascia here, one which is on the rectum and the other one which is on the vagina. And these areas glide very beautifully, so please be in the correct plane and push, and you will be in the correct plane. Fat belongs to the rectum, as Dr. Pantambekar has made a universal common comment. So we keep that and go in there. So that is how you dissect that side. Here, as you can see, I've used a stitch and passed it to the epididymis epiploicae and tugged it up, so my bowel is completely away. So that is one trick which you can use. Again, on the other side, the same way, Latzko's Okabayashi, and I'll go ahead instead of wasting time. Now, this is the Okabayashi space. If I'm cutting that peritoneum, I've cut that peritoneum. Now my ureter is here. The same inferior hypogastric from there and here, both sides you can see. Can you see the inferior hypogastric nerve now? This is my ureter, this is my uterosacral, and over here, medial pararectal space of Okabayashi space. So I'm cutting the uterosacral there, and when we are doing a nerve-sparing radical hysterectomy, you need to preserve the inferior hypogastric nerve bilaterally as well. Now we take a lecture on that if we have the time, but you know the Quiller's classification now has changed. We don't use a fibrocartilage anymore, and we have ABCD instead of the type 1 and all that. So the ABCD classification in the Quiller Moro is what we are using nowadays. Right. So this is now when I'm doing the de-roofing of the ureter. So if I'm going to de-roof the ureter, I've come in anteriorly. Now again, when you're doing nerve sparing, you need to do the bladder pillar, save those areas. The vesicovaginal space is what you're dissecting. Obliterated umbilical I'm holding. This is the ureter. And I'm dissecting this area using my uterine artery like a pull and pushing, catching it from here and putting it towards the uterus like so. And you can see this is what is giving me my traction, this uterine artery cutters which I'm using. And then dissect it till the time you see the ureter entering the bladder. And this will be the bladder pillar or anterior pillar, and below this there will be the nerves. So when you are doing the nerve sparing, this is called the fourth space of Yabuki. This is Yabuki space. All these spaces become extremely important if you're training in radical. And when you're doing a radical hysterectomy, these spaces and these areas become extremely important. Otherwise, in our routine practice, like I said, we're taking the ascending uterine, which is here. So we don't even come in this area. We are far, far away from this area. Because we are cutting over here when we do a normal hysterectomy. But when we are doing a radical, then we need to take all this vagina. That is why we need to lateralize the ureter, and hence all this lateralization ke liye you dissect the ureter right up to the bladder. Moving on to the lateral pelvic wall when we do the pelvic lymphadenectomy. Again, the same way, these spaces are open. You can see the external iliac, you can see the ureter, and when I'm doing a pelvic lymphadenectomy, again people have a lot of myths. How do the lymph nodes look? This is all that the lymph nodes are. You can see I'm just cleaning onto the external iliac, that's external iliac artery and the external iliac vein. And don't take these lateral ones. You can see the psoas muscle and the genital branch of genitofemoral nerve. So you don't want to take all that. In case you don't have an involved node, try not to take the external the lymph nodes lateral to the external, because otherwise you'll have lymphedema, and you can just take these lymph nodes between the external iliac and the internal iliac, and the obturator are the most important lymph nodes. We do sentinel lymph node nowadays in C endometrium, where we inject ICG into the cervix at 4 points, and then we see where is the first. If the first lymph node is not involved, it is very highly unlikely that the other lymph nodes will be involved. So that is something which you can prevent instead of doing a conventional lymphadenectomy. So this is the entire lymph node bundle. That lateral, there is a posterior division of the internal iliac, which you can see going down. To be a good surgeon, you have to know each and every part of the pelvic anatomy very well. Then your fears will go away. That is why I am painstakingly taking this lecture, because to imagine open anatomy and laparoscopic anatomy are two different things. Between the external iliac vein and the internal iliac vein, you can see the bifurcation. This is the obturator nerve. So now I am going on to the obturator nerve. I have, in my many years of experience, cut the obturator nerve also once, and I have stitched it, and patient was okay. I was quite lucky that way. And you can see the obturator internus muscle. Now all these pelvic spaces are connected to each other. We in our head imagine that the space of Retzius is anterior, this is posterior. These spaces, now if I go from here, you saw the obturator internus. If I go from here and open the space of Retzius and see the obturator, it will all come together. So all these spaces are connected, and hence the pelvic infection or tumors on one side, it spreads to the other side. So again, just a quick revision: psoas, genital branch of genitofemoral nerve, external iliac vessels, obturator between the external and internal iliac vein. This is the picture we should all have in our head to know exactly what. And we are going down and down and down. So when you're superficial, so in 3D you understand this better, but when you're superficial, there's no issue. When you're going down, the nerves will also come. So the deep uterine vein is your landmark, that you will not go below the deep uterine vein. The space of Retzius is, again, nowadays we are very, very interested. So this, all I'm doing is I'm holding that bladder, pulling it down, opening the space of Retzius. This is the avascular, beautiful space. Between the two obliterated umbilicals, you will hold this and go down. You can see the bladder going down. And the first thing which you'll see is the lighthouse. You can see the pubic bone. So that is the lighthouse effect. Keep going down, and If you come here, you will find the obturator. So that's what I was talking about. You can see the obturator nerve from here and from there. So open this, keep going down. This is a lateral cystocele repair which I am doing, in which if you can see this, what happens in a lateral cystocele, the tissue between the vagina and the arcus tendinous fascia pelvis, the pubico-cervical fascia has separated. So you stitch it. If you do the conventional bladder buttressing cystocele, what you taught in medical colleges, those will after some time make it worse. So in Birch, in lateral cystocele, this is the correct method of doing things. So you are taking, I'm passing it through the arcus, through the obturator internus, and passing it through the paravaginal tissue. I just have a thumb there. In the para, you don't need a thimble. This is theory ka part hai ki thimble chahiye hota hai, you will go that deep. You can never go that deep. So here I'm passing it through the paravaginal tissue and anchoring this toned anterior part. Now if I go here, I'll see the ischial spine. Okay? So when it comes to the pelvic floor now, the organs, pelvic floor, the organs, the bladder, the uterus, vagina, rectum, all of them are suspended on the pelvic floor. And these organs are not stationary organs like your muscles in your abdomen. They are hollow organs, they get mobile, they get filled, they get emptied, they need to provide support as well as a lot of functionality. That is where we differ from our surgeon friends. Our surgeon friends can put a mesh and forget about it because that muscle doesn't have to do anything. Whereas the vagina has to empty the urine, has defecation, micturition, sexual intercourse, so many functions. So the meshes and the other things need to be more dynamic. The support needs to be more dynamic. And God has made it dynamic. How? Because if you see, when you have your levator attachment, that comes from the arcus tendinous fascia pelvis, which is a condensation from the pubic bone to the ischial spine of the obturator internus. This is your arcus tendinous fascia pelvis. And so when you have your innermost part of the levator ani, which is like a sling here, this is the puborectalis part. Then the pubococcygeal part and the iliococcygeal part. All these are attached to no bone. They are attached to the arcus. That is what gives it a spring-like structure and a mobility and the dynamism which the levator ani has. So let us not try to sort of manipulate with this by taking levator stitches when you are doing rectocele repair vaginally, etc. Because then it will cause a lot of issues there and a lot of disparity. How this, we again imagine that the pelvic diaphragm is very thick, very big, but this is a cadaveric demonstration of the pelvic diaphragm, and you can see the gaps. And you can see this is the posterior part, the intramuscular gaps. You can see their thin structures. So they also need to be supported, and that is why today we are changing to mesh surgery. Why are we changing to mesh surgery? Because we know that in collagen is the main thing, not people used to say chronic cough, asthma, chronic constipation. These are the reasons of prolapse. Now what I'm telling you today is completely opposite to what you have learned. Today we know that collagen is the main cause of having issues with the prolapse. So when I practice in Dubai, my Arabic patients, even if they've had 8 deliveries, they will not prolapse. Whereas Indians and Pakistanis, after one delivery, everything will come down. So it is their collagen which is important. So here you can see, you have the, this is the part which we are interested in, which is the puborectalis part or the innermost part of the levator ani. So here I am dissecting the transmesorectal plane. Okay, so I started from the sacral promontory. So this is how I do my prolapse, whether wall prolapse, nulliparous prolapse, or uterine prolapse. We do it now like the same way. This is the transmesorectal plane. You open this plane, and you can see the sacral promontory there. There are two spaces here. One is the immediate subperitoneal space and one is this space which is the transmesorectal plane, which our colleagues in surgery also use for rectopexy. So open this space. I know a lot of gynecologists are not very familiar with this space, but now we have to get familiar with this space. You can see the angel's hair or the champagne effect or gas or whatever else you may call it. I'm lifting the rectum up. I'm going more medial. And this is also called, lower down, it's called the holy plane of heel. The holy plane of heel will be used not only for prolapse surgery but also for endometriosis now when you want to resect the bowel and you want to resect the bowel or you want to do anything, because now you're getting a lot of bowel endometriosis. So these spaces become extremely important here. So here you can see your ureter is already crossed here. Now you are at the pelvic floor. So there is no chance of you damaging the ureter. My direction then changes to the uterosacral ligament. Your nerves have gone here. Your T-hypogastric nerve is lateral to the uterosacral, ureter is lateral to the uterosacral. And now I'm going down, tugging the rectum properly. I'm not going into the vagina or into the rectum. Being in that fascia so that the mesh which I put can glide there. It's a case of nulliparous prolapse. So this space is extremely important. And here you can see, you go down till you see the puborectalis part of the levator ani. So here I am exposing the levator ani from here. So here bilaterally I have exposed the levator ani, the puborectalis part. This is the levator ani. Okay. And if you just anchor and take the cervix and anchor it to the sacral promontory, it's useless. The mesh should be anchored to the levator ani on both sides, sacral promontory on one side, and then the cervix should be anchored to the mesh. So here, this is the levator ani. The innermost part is the puborectalis part, which forms like a sling. And in order for the rectum to glide on top of this, you cut the mesh in between. And don't go in the wrong plane, otherwise you will damage the nerve. So here, this is the mesh. I'm using vital tacks. Like you have the tackers, you have these vital clips which are there, absorber tack or secure strap, and anchor the mesh there onto that levator ani, then onto the sacral promontory and stitch the cervix. The sacral promontory now which I'm anchoring to. Have they started the anesthesia on the next case?
Yeah, dripping is started and now.
Case is already ready.
Okay, so
Drip.
I'll just finish this then fast. So here I'm anchoring this with no tie. You take the uterosacral also and then anchor it to the, this is a permanent suture, this is ethyl bond, always I use ethyl on because I like the viability of ethyl on more. So respect the transmesorectal plane which I showed you how we resect between the rectum and the sacral promontory. There are two layers again. You have the parietal peritoneum, you have the visceral peritoneum. All the viscera are covered with the peritoneum. In between these two areas, you find a very nice plane. This, only in two places it will not be connected, which is the Valde's fascia septa, where it will be stuck. Otherwise, this is called the holy plane of heel, H-E-A-L-B, and this is what we use for cutting out the, when we are doing a rectal also. Again, very important, all this anatomy will be used for endometriosis especially. Endometriosis, certain landmarks will be there. Your obliterated umbilical, rectum, holy plane, all that will be there. I think with that we'll stop. I'll go on to the case because they're painted and draped. Any questions?
everything was crystal clear. I think those who are doing advanced laparoscopic surgery, they have to be knowledgeable about all these things. Otherwise, complications faces.
We'd also like to make an announcement to the audience who's there. Me and Dr. Neelu are coming together. Sunrise and Askaloka are coming together. And what we're doing is I'll be coming here every month. And every month I'll be doing the cases here, OPDs here. And also we will be starting a hands-on training program in Bihar. For the first time, I think there's no hands-on training program going on. So we'll be starting the hands-on training program also over here. Madam. And we'll fix a date. Hands-on training will start from May. Let me just get settled and understand how the scene is here. And in every month we will be starting first with the cases and the OPD. So any cases, OPDs, please feel free to call me or Dr. Neelu. You can discuss on any case you have on the mobile also with me. We'll form a WhatsApp group and you can post your questions and we can answer that, or you can get in touch with me or her directly. Thank you.
So really, thank you, Nikita. And just announcing that every month, I think that is 24th, roundabout. So that I will fix and on every month she will come for OPD purposes and for all the cases that in the meanwhile for the whole month that will be collected or she will do. And together the most important thing, hands-on training के लिए हर लोगों का बहुत लोगों का मेरे पास आया है कि hands-on training मिलेगा कि नहीं अगर हम तो definitely hands-on training will be here. Everything at just protocol जो दिल्ली में रहता है, so 1-2 महीना समय लगेगा सारा उसका जितना भी हमारा tools होना चाहिए, everything I have to say, और hands-on training मिलेगा and the patient वो पकड़ के कराना इनका duty है, and the something in the meanwhile will be the audiovisual classes from there.
With the hands-on, please understand that I will go according to your level. If you don't know how to put a trocar, I can't give you radical hysterectomy. Thank you.
The chapter we are learning today is going to save someone's life tomorrow. The chapter we are learning today is going to save someone's life tomorrow. Thank you, Dr. Neelu ma'am and Dr. Nikita Tehan ma'am for sharing your knowledge and experience. Now our second OT will be shortly started.
Actually, there are so many cases for the advanced surgery, but वो हम लोगों के बहुत काम का नहीं रहेगा. कैंसर सर्विक्स है, लिम्फेडेक्टमी है, वो हम लोगों के लेवल के ऊपर का है. तो सिंपली हम ये चाहते हैं कि जितना भी लैप्रोस्कोपी है या जो हम लोग TLH वगैरह जितना करते हैं, जितना डायबिटीज को वो हम लोगों के लिए ज़्यादा अच्छा है. So initially we will have 2-3 cases like that, simple cases. लीजिएगा मैम. नीलू. कहाँ गया अंशु
एंट्रेंस को पहचान ही नहीं पाए.
सब लोग को नहीं, जस्ट एक मिनट मैम, आप लोग एक मिनट आइए प्लीज. उस तरफ चले जाते हैं, उधर से व्यू. हाँ मैम, जस्ट एक
बढ़िया चल रहा है. सही कहा. मुझे बताइए कि कब हो गया हमारे. हाँ वो तो दिखाए अगर आप बोलिएगा तो हमको बात रजिस्ट्रेशन. हाँ सेट हुआ.
You all know that Fox is organizing a workshop, Foxy PPH1, and you all are invited to attend this. So kindly get registered for that conference. Because we have already finished early bird registration. It's on 30th and 31st of March. Whole 2 days focused on postpartum hemorrhage. We are ready to welcome all of you. Thank you so much. Secretary Partner and Gandhi Society. Just a round of applause, Amita. कुछ नहीं, बहुत छोटा सा है, रेस्पेक्ट करने का तरीका बराबर. कोई बात नहीं, आना ही बहुत है. क्योंकि मैडम लोग को निकलना है, आपका एक प्रोग्राम भी है.
इसमें रख लूँगा आपका.
भाई बहुत ताने बजा रहे हैं. ये मेरा
So one more announcement, as Amita has told about PPHCon, but in that we will be having a workshop
That is going to be a wonderful workshop that will be on 30th of March, and we will be having a live and both video sessions in that workshop, and we will be showing all the cases related to PPH as intra-aortic artery ligation, compression sutures, devascularizations, and how to manage low uterine segment bleeding, upper uterine segment bleeding. All the cases will be there. So it is going to be a very wonderful and to be learned all the cases. So please get yourself registered for that PPH Con, and I will be welcome. I will be there to welcome all of you in PPH Con workshop. Thank you.
So nice, ma'am. Good afternoon, everybody. I must congratulate Dr. Neelu Prasad. Actually, she was a DNB student in Kurji Holy Family Hospital, and now she has, really developed herself. And I really appreciate. ये वही हो गया जैसे गुरु गुरु चेला चीनी. वैसा ही लग रहा है. Very nice, very nice. I really appreciate.
Thank you, so nice, ma'am. Thank you, ma'am.
Check. Hello. Check. Hello.
चलिए केस लग क्या जाएगी रेडी
रजिस्ट्रेशन करवा लेते
दोनों का 2.1
लेटेस्ट निकाल लीजिए
अच्छा उसके बाद आप ना बारे में बता किसी को बताया आपके बारे आपके बारे किसी को बताया आपके बारे में बता कॉलेज में नाम उसके बाद समस्तीपुर मेडिकल कॉलेज में उसका कॉलेज समस्तीपुर में हम तो कल किसी से बात कर रहे थे अपने चैम्बर में हम आपको बना दिए चला दिए वापस मेरा प्रोग्राम नहीं कर रहे हैं कोई आपको नहीं जान रही
It's for hysterectomy. Is the audience with me? Am I connected? Audio visual? Am I connected? Audio visual?
हेलो
ये इधर
अरे
वो ऐसे अब इसको ऐसे हाँ ऐसे कर
हाँ ठीक है साउंड आ रहा है
इसको ऐसे कर नहीं ऐसे कर बस सही नहीं बस ठीक है बिल्कुल फर्स्ट क्लास नीचे Am I connected? Should I start?
Yes, ma'am.
So again, direct local entry again to the right because it's also a TLH. So what I'll do is let me just see how it is inside. I may dissect the spaces, whatever anatomy which I've shown you right now. I'll show you the natural pelvic wall anatomy and the space of Retzius right now. So you'll be able to understand what I'm saying again. Okay. Nilima, is that okay? Should I dissect and show in this case? Needu ma'am. Okay. So here again, Lee ranks point. Patient is a little fat, so I hope I can show this. Sure. Gas on करो head low first. Gas on head low. ये टॉप लाइट बंद कर दीजिए, पीछे कर दीजिए. हेड लो दे दीजिए प्लीज. हेड लो दिलाया. नाइस वन. शाबाश. अब तो खड़े हुए हैं. ओके. हेड लो कर दीजिए प्लीज मैक्सिमम. करते जाओ करते जाओ करते जाओ करते जाओ करते जाओ. ज्यादा देर नहीं लगाऊंगी, जल्दी कर दूंगी सर्जरी. तुम हेड लो दे दो बस. और so now that we've done the lecture, it's easier for me and for you to understand. थोड़ी brightness बढ़ा दीजिए, light बढ़ा दीजिए. प्रकाश दे दीजिए बस. हाँ. allegiance क्यों है? PID बच्चों के साथ. So again, just natural to the inferior epigastric, you just go in. Head के बिना बेटा. एक थोड़ा गैस का प्रेशर बढ़ा दीजिए. नीमो बढ़ा. नहीं हाँ वो तो बढ़ाइए. इसको भी 16 कर दीजिए बस. नहीं इतना नहीं. हाँ बस. भाई नीमो फ्लेटर है, अपने आप बंद हो जाएगा जब प्रेशर ज्यादा होगा. मैम के पास एलन के बहुत अच्छे इंस्ट्रूमेंट्स हैं. शी हैज द insufflator, everything of Allen. Mama, school on the right.
Ma'am, could you please elaborate on the port positions?
So, बाहर से दिखा दो port position. External camera. ये थोड़ा unentangle करो. Unentangle करो. Unentangle करो. मामा स्टूडियो में राइट पोर्ट में पूजा चल कर. नहीं not to blunt. Focus. More. बस. That's it. So here there are a few adhesions which we'll just start with doing a little bit of adhesiolizes here. Hysterectomy is a 15-minute job in this case, but since I've just taken a lecture on anatomy, I thought I'll be able to show you the anatomy and you'll be able to follow better. Inshallah. So sometimes it's good not to have too many cases, then I can show more in one case. Push and hold. You can see that the round ligament is being stretched here. Can you understand that part? So this is a lateral window which I'll open between the round and the IP. Okay? As lateral as possible. जितना push कर सकती हो उतना push कर. शाबाश. Please remember you don't need to do this in every case of TLH. I'm just doing this for demo purposes. गैस निकालते रहो एक पोर्ट से. मेरे सर के ऊपर से लाइट हटा लो. नहीं आप फील्ड में लेके आ रहे हो. पीछे आ रहे हो मेरा. You go parallel to the IP. So that is your direction. पुश करो थोड़ा. मेरे सर पे लाइट आ जाएगी प्लीज. सर टूटेगा मेरा. अरे यार एक सेकंड. I'll just get adjusted. Somebody is putting light on my head. ठीक है? Okay? The anesthetist is wonderful. As he promised, he's not using nitrous. One of the worst things to use in laparoscopy is nitrous. Because it will just unnecessarily inflate the bulb and spoil your field. Smoke out करता रहे बेटा. पीछे पूजा रोज का काम है तुम्हारा. So here you can see the ureter. Okay. So here what I'm doing is between the ureter, the first structure you can see here is the psoas. Just नहीं रुक जाओ, मेरे को पहले ये ब्लीडर पकड़ने दे. फालतू में मेरा फील्ड खराब होता है. सब बस कर दो. So here what you can see is this is the psoas muscle. Can you see the psoas muscle? Neelima, some audience interested है ना इसमें?
Yes. Yeah, we are all there with you.
Actually, I can't hear anything. तो मुझे लग रहा है I'm talking to myself.
No, we all are mesmerized due to this thing.
Okay. So here you can see the psoas muscle. ये बंद करो, गैस जो लीक करा रहे हो. Here you can see the genital branch of genitofemoral nerve, and between the external iliac and the ureter, I'm opening this space. Okay. पंप निकालो गैस. अंदर आओ पूजा. So here, as you saw in the lecture also, you take the round ligament as lateral as you can. Okay? अब smoke out कर दो बेटा. And herein you will get your lateral paravesical space. अंदर आओ पूजा. Push your mama's through. Push. ऐसा. और नीचे हाथ. शाबाश. ऐसा रहेगा, हिलना नहीं. ठीक है? So here what you will see is in a second. अंदर आ बेटा. अंदर आओ. राइट के लेफ्ट में टर्न करो. So you can see the obturator vessel is here. See the obturator. देखो obturator now. ये vein artery nerve दिख रहा है?
Very visible, very clear.
मेरे को ऑडियंस की कोई आवाज नहीं आ रही थी, इसलिए मुझे लगा कि कोई देख रहा है, मैं ऐसे फालतू में चेक कर रही हूँ.
We are watching very carefully.
अच्छा.
Very exciting.
And here you will see the corona moti. Can you see the corona moti here?
Yeah.
And here you will see the obturator torus passa. ठीक है? पीछे आ जाओ. ठीक है? So that is the lateral. बाद में डिस्कस करना. ये lateral paravascular. I'm with you, okay? Discuss on the slide. Paravascular space. Okay, so for cancer surgery, these spaces become important. Otherwise, they are not so important. This is the obliterated umbilical. Okay? So that I'm using to tug. थोड़ी मोटी है पेशेंट, तो जो CA cervix में थोड़ी पतली मिलती है. But nowadays with CA endometrium, we are getting a lot of this. So this obliterated umbilical is going to divide the paravesical space into medial and lateral. So here I'm just going in here and show you the medial, but अंदर का, like you know थोड़ा right में. बहुत फैट है इसमें, पीछा देखो, थोड़ी सा डिसेक्ट करके आ गया. एकदम इसको थोड़ा पुश कर, शाबाश. This is the internal area now, and this is the Latsko space. So what is the Latsko space? At the cost of repeating myself, between the ureter and the internal iliac, this triangle is the lateral pararectal space or Latsko space. Alright? And medial to this ureter over here is the Okabayashi space. Okay? So this is Okabayashi. Now, if I cut this peritoneum and make it open, this is the uterosacral and this is the Okabayashi is here. So you can approach from here or from here. Okay? So this is the Latsko space. Sorry, Okabayashi space, medial pararectal, and this is the lateral pararectal. Okay. See the length of the uterine artery you get. Huge length. And अंदर आ बेटा. Clarity लग रही है. हाँ, right hand को थोड़ा देखते हैं. See, this will be the only one which will be bluish. Rest, every vessel artery is a little whitish. Can you see the difference in the colors? So when you start looking at tissue, identify the tissue by not only its position, but its texture, color, everything else. Then only you will become a better surgeon. So, if I go down here, again, elevator. Okay? Okay?
Yes, yes.
And the ureter lies in the fork between the artery and the vein. So, here is the ureter. थोड़ा push कर.
This is ureter.
Yes, which I'm holding with the Allen. You don't have to do this in every TLH. Don't take the wrong take home message. I'm just doing it for demo because I took a lecture on anatomy, so I thought दिखा भी दूँ. Bladder full है. देखो कहीं से ब्लॉक हुआ हुआ बेटा. यूरिन लाइन ब्लॉक है. ठीक है? So you can see this uterine. You can see the superior. I'll show you all the branches of the internal area. That is also interesting somehow. Lots of people don't understand that. आजा बेटा अंदर आ.
ये ऊपर से प्रेस
ये सुपीरियर रेक्टल है,
ऊपर है इंटरनल
इंटरनल इलियक यहाँ है, ये ऑब्लिटरेटेड अम्बिलिकल है, ये है आपकी यूट्राइन जो ऐसे जा रही है, और ये है सुपीरियर रेक्टल, एंड यहाँ पे है आपकी पोस्टीरियर डिवीजन। Can you see the posterior division? ठीक है?
yes.
And if I have to see the obturator nerve, you can see the internal iliac vein, the bluish color. Between the internal iliac vein and the external iliac vein, I will just go here and I will find my obturator nerve. That's थोड़ा ब्लड लग रहा है सेक्शन में ना, छोटा कोई फैक्ट से ब्लीडिंग है, तो यूट्राइन बांध देते हैं। हार्मोनिक ऑन वन,
From the origin, bleeding बंद हो जाएगा।
see the peristalsis of the This is the superior rectum, don't take that, bladder का blood supply जाएगा, suction दे दो भाई और push करो, ओ भाई push करना, और हाँ superior vesicle and superior rectal बोल रहा हूँ, sorry, thanks पूजा, I've become old. भैया प्लीज सक्शन ऑन कर दो, प्लीज सक्शन ऑन कर दीजिए प्लीज। हार्मोनिक फोट पकड़ो, बस पीछे ठीक है। So we can keep on dissecting. I can go and show you the sciatic nerve also, but I'm sure that Dr. Neelu Prasad will have a heart attack. मैडम कितना तक करना बता दो, बंद करें।
क्या सुनना चाह रहे हो?
sciatic nerve दिखानी है क्या? और तो
पूछ लेते हैं, ऑडियंस से पूछ लेते हैं।
आपका
उतना एडवांस सर्जरी देखो, इतना ही दिखाओ जितना हम लोग करें और कर सकें।
ओके,
है ना? नहीं तो फिर तो लगेगा इंग्लिश पिक्चर देख रहे हैं ना, लैंग्वेज समझ में आ रही है। केवल एक्शन देखते रहेंगे कि किधर जा रहा है क्या चीज।
Okay, so here you can see now, what you can see is the obturator nerve. You can see the obturator foramen here. Can you see that? Very clearly? What where? TV dekho. See, this is the obturator nerve. This white shiny structure. Nothing can be there other than this obturator nerve. Okay? And the vessel which connects the external iliac to the obturator is the corona motti. This is the dangerous part, because what this stupid vessel will do, this got no valves. I will show you clearly the corona motti. So this area, enter at your own risk. I'm entering at Neelu's risk. Can you see the obturator muscle now? This is obturator muscle, जो आगे से भी दिखता है, आगे से भी दिखाऊंगी, दिखा? यार कोई कुछ बोल ही नहीं रहा। See this, this is corona moti. This is the obturator muscle. Can you understand that?
Yeah, yes, yes. Very nicely looking.
Very nice. And कैमरा सीधा पकड़ो, तनीषा की बात बाद में सुनो. तनीषा बाद में बात करना प्लीज. So if I go in here, I'll show you when I come here, I'll show dissect the space of radius also and show you. Can you see this, this and this and this? This is the corona moti.
Corona moti.
Yes. डरो तो इससे डरो. Don't get scared of the uterine, that's your friend. डरो. ठीक है? Now, I'll show you the anterior space also while we are at it. Because मैडम ने बहुत कम cases रखे, तो कुछ टाइम पास करते हैं. पिशा. नहीं, एक टूथब्रश पर दे दीजिए बेटा. टूथब्रश. हिस्टेक्टोमी करके फिर स्पेस ऑफ रेडियस डिसाइड करते हैं ना. ब्लड हो जाएगा. 10 मिनट में पहले हिस्टेक्टोमी कर लेते हैं, फिर स्पेस ऑफ रेडियस डिसाइड करते हैं. You know, the myoma screw which has a central spiral is the one you should be buying. Those are the good ones. पकड़ो. Bipolar डाला. Bipolar डाला. Again, risk reducing salpingectomy in every case. लेफ्ट फुट में बाइपोलर डालो. फुट मेरे पास. लेफ्ट फुट बाहर करो पहले. शाबाश. लेफ्ट आप क्यों दिया है? राइट आप तो थोड़ा. ओ भाई यार बहुत सो रहा है वो. पकड़ो तनीषा. Horizontal round बेटा. Round ligament horizontal. Yes. See, all these are chlamydal lesions. Can you see that? I'm sure if I go to the liver, I'll find pituitary also. सर आप क्या कर रहे हैं? बस 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 बस. ये भी एलन वाला इधर आ जाइए. इसको भी ऐसे रख दीजिए, उसको भी वैसे रख दीजिए. I want both. So now I'm showing you how I'm using the Allen cutting. Can you see that? This is unipolar. No, this is not. Sorry, this is cutting bipolar. अंदर आ जाओ बेटा. Sure. This is taking the need for ligature.
So you are using both unipolar and bipolar.
Whatever she has in her roti, I'll use. She has both these.
Okay.
There are workshops where I have done with only bipolar also. Whatever is available, we make maximum use of it. This is a luxury. Dr. Neelu's OT, सब कुछ है. Keep a little distance from the uterus. Don't go too close to the uterus.
Okay.
स्मोक आउट कर दो. खाली इसमें बाइपोलर में और ये सब शरण में एक ही प्रॉब्लम है, स्मोक ज्यादा जनरेट होती है. ये सारे एडवांस बाइपोलर है. सो these are much better than the previously the ones which we were using. ये नीचे क्या डाला है? नीचे क्या डाला है? Come back. What is this coming here? Myoma screw is coming through and through. ये कौन सा myoma screw है भाई? ये तो modern weapon है. दूसरा दे दो. तो पहले केस में दिया था ना, वही दे दे भाई. ये मत देना मुझे वापस. हाँ यही दिया था. कोई बात नहीं. पकड़ो ऐसा, बस कुछ नहीं करो बेटा, ऐसे करो बस. ठीक है, ऐसे ही रहना. पूजा बस. अभी स्मोक आउट मत कीजिए, मत कीजिए. ओके, थैंक यू सर. Toothbrush in the center. Toothbrush in the center. Thank you. Camera straight. Keep the camera straight, doctor, please, better. So whenever you want to dissect between two spaces, suppose you want to dissect between the bladder and the uterus, you have to hold those two structures. What people do is they hold this structure and then they don't get a plane. Hold the bladder. And when you hold the bladder, hold it with a sharp instrument. It will not tear. Blunt ones will tear. Okay? Smoke out Keisha. See now, when there is no previous cesarean, how nice the plane is. Now we'll take the posterior part. There's no hard and fast rule that you have to take the posterior first or anterior first. Whatever you feel like. Right, take that. With the uterus again. Chlamydial variations. Center में bipolar है. Vein bleed करिए. Center में bipolar. इसमें मैं बोल रही हूँ दोनों को switch दे दें मुझे. Please bye.
Hello ma'am.
Sanjay.
I have a question.
Please.
Can we go for bladder resection as a first part of surgery while doing laparoscopic surgery?
See,
can we start with it?
You can do whatever you want to, but at the end of the day, this is a sunrise method which we standardized. So count karo. So we've done it for certain reasons. This is, if you do it like this, everybody will, in sunrise we're doing it like this. And we found, because when we designed this method many years back, at that time there was a lot of confusion. Yeah, echo ho raha hai, mera awaaz band karo yaar. That time there was a lot of confusion कि क्या पहले लेना है, क्या बाद में लेना है, myoma screw right से आए, left से आए, कहाँ से आए. Then we sat in for a week and standardized this procedure. Camera सीधा पकड़ो, horizontal करो. Right, give me both the foot switch now. ये ध्यान रखो bipolar. टेढ़ा करके रखो और ऐसे बस आजा पूजा सक्शन दे दो लेफ्ट फुट में सक्शन दो लेफ्ट ये लेफ्ट है और इसके बाद में हार्मोनिक डाल देना ठीक है 5 मिनट का काम है छोटा सा यूट्रस है सक्शन का प्रेशर बढ़ा दे भाई प्लीज फुल है डायरेक्ट लगा देना भाई बैक के नीचे पोट पकड़ हार्मोनिक डाल अंदर This is the posterior peritoneum which I am taking now. What this does is again it will take away your ureter laterally once you cut the uterus sacral. So your left ureteric injuries will be less. All this, the basic problem with hysterectomy, why people got scared is ureteric injury ज़्यादा now. So once your ureters are safe and you are doing it properly, then nothing will be a problem. Understood?
Yeah.
Smoke out. ऊपर आ जाओ इसमें कुछ नहीं बचा है यूट्रस में खुद मेरे पास दे दो प्लीज ये वाला थोड़ा सही बस खलास मुझे हैंड पे नहीं चाहिए मुझे खुद की आदत है लॉन्ग सर्विक्स
Ma'am would like to know what type of device, energy device Allen is. Is it the same as
it's
a
an ultrasound. It's an ultrasound device. So basically, bipolar and ultrasonic are complementary sources. What the bipolar does is it coagulates the blood inside the vessel, whereas what the smoke out mat karo 1 minute ke liye. What the ultrasonic does is it co-obtains the intimal lining of the vessel. Okay, and makes it stick. So because it does that, it's a vessel sealer.
Okay.
And ma'am, what is your preference? Where would you like to use the bipolar?
Anything beyond the uterine, I don't like to use a bipolar. See, when I see these vessels bleeding, then I know that I've gone too low. These are vaginal vessels. What? Wall close karo, Shujji? So this is one of the markers which made me realize कि यार bleeding थोड़ी ज़्यादा हो रही है. So definitely I've gone into the vagina. Cervix will not bleed like this.
And ma'am, since you are not using the uterine manipulator, how do you make out the site where to cut the vault?
So basically it will become obvious. It becomes obvious and हाँ नीचे जाओ. So, here, what is the advantage of this procedure? मत करो ना वैसा. Is that your vaginal loss will be minimum. So, post-operative, these are not very old patients. These are 40-45-year-old girls. So, post-operatively, her sex life will not be affected because the cervix, the vaginal loss will be minimum. Vaginal length will not be toothbrush center. So those are the biggest advantages of laparoscopic hysterectomy. ये मैंने lateral vaginal wall ले लिया थोड़ा. एक बार इसको बस कर देते हैं. देखा. यहाँ पे ना I've unnecessarily gone down a little. That's my mistake. Doesn't matter. It'll come in my suture. But I'm just. पकड़ो. PP कम कर दीजिए sir. As far as post-op pain management goes and other things, we give a tab block in every patient. transversus abdominis block, which Dr. Pooja and Dr. Nishan will demonstrate now after this case. Tap lock लगा देंगे. So opposite side uterus sacral gone. You saw the same steps, na?
Yes.
So it becomes easy, na? Everybody knows कि अभी next क्या होने वाला है. Your OT team, your anesthetist, everybody knows कितना time बचा है case में. So that is done. Now you just go on the right side and chop this uterus off. पकड़. Push करो वो side. Tubes are dirty, and you see this fat around tubes. If you have infertile patients and chlamydia wala infections, you have this lot of fat around the tubes. It's a hydrosalpinx. And a paravein cyst as well. Center port पकड़ो. लेफ्ट फुट देखो. फुट निकल आया बाहर एक बार. लेफ्ट फुट दिखा दो. हाथ छोड़ो मेरा. हाथ छोड़ो मेरा. Okay. Yes, madam. Any other questions?
No, ma'am.
Hello, Nikita. Good morning. It is Dr. Geeta Singh from Patna.
How are you, madam?
Good, good.
Pleasure talking
I have
to you.
seen your surgery since last half an hour, a bit more than that.
Are
You are doing a fantastic surgery.
It's an honor for me.
Okay. And I hope you are going to show us the space of radius dissection also.
Yeah, sure.
I would like to see the pectineus ligament exposure and all that.
अभी दिखाते.
Okay. Very good surgery you are doing.
Thank you, ma'am. And when coming from you, it means a lot. You've seen me like a child grow up in
Yes,
front of,
yes,
you know?
I do remember that day when you had come as an assistant to Dr. Hafiz
Yeah,
to my place. Yes, many, many years ago.
Yeah.
And that's good. You have done so well from him, just doing as good surgery as Dr. Hafiz does.
Thank you, ma'am.
Nikita,
Yes, yes, yes.
we all are adapted to do TLS with uterine manipulator, but most of the surgeon, it is some extra benefit to that, not using, or it's the fancy or the choice of the surgeon.
I'll tell you what the advantage is. See, when you have a normal size uterus, it doesn't matter whether you use a manipulator or an 8-10 week size uterus. It doesn't matter whether you use a manipulator or a myoma screw or whatever. But when you have a larger uterus, okay, then you will find it very difficult to manipulate with the uterine manipulator because the upper part will become very difficult. So why not learn the correct way? Abhi you will be able to manage, there's no doubt about it. With this size uterus you can manage with anything, even with a grasper you can do it. There's no need for anything. But when it comes to a large uterus, 36 week size uterus and all that, which come to us routinely, then you will find it difficult.
I think Dr. Neelu and Dr. Nikita, in my experience, there is another advantage of a screw. The whole thing is under your control. And you can move the uterus as you like it to be moved. While a vaginal manipulator, it is not in your hands and depends upon the quality of the person who is handling the manipulator. So sometimes things are not so well controlled by you when it is being manipulated by a. Of course, if it is very experienced and good person sitting at the vaginal end, it is good, but most of the time that is a great trouble to the surgeon. Once you are used to using the screw, the things are under your control and you can manipulate yourself and then just give your assistant to hold it like that. So that is another advantage of using a screw.
Large size uterus especially, ma'am. Very large uterus, because we get a lot of very large uterus. Then it becomes difficult. In those cases, I inject the vasopressin also and do all that because the backflow bleeding becomes a little difficult. And ureteric dissection also should be very properly done in those cases. Now, why I'm doing all this is because I've dissected the ureter in this case. So I'm going to show you exactly, because people again have a lot of confusion in this part I've seen. So I'm going to take away your fear of hysterectomy after this. What is your fear of hysterectomy? Your mother-in-law, ureter, no? So we will get rid of her. एक बार मेरे को प्लीज ये दे दो, हार्मोनिक दे दो सेंटर में, पोट पकड़ लो। ये सब मैं इसीलिए डिसाइड कर रही हूँ खाली दिखाने के लिए आपको कि यूरेटर कितना दूर है, ताकि आपका फेयर निकल जाए, ठीक है?
How you maintain proper pneumoperitoneum? When you cut the walls, then there is leaking of.
Suchi. She is going to show you how she is maintaining. Poor girl is having a handache now. See, I'm cutting the posterior peritoneum. अंदर आओ. एक बारी सक्शन रेडी रखना भाई. इसके बाद मुझे सक्शन चाहिए नीट करके सबको दिखाने का है. सक्शन ले लो भाई. पोट पकड़ो सेंटर में. चलो. Because I showed you in the last case, however, I'll show you again what I mean by transverse part, ascending part, uterine safe, all that. क्या भाई एक बारी सक्शन ठीक कर दे यार. थोड़ा सा बढ़ा दे यार प्लीज भाई. वो खाली बोलता है देता नहीं है. सुनील उसको बोलो ना प्लीज. सक्शन का प्रेशर दे दे 2 मिनट के लिए. अरे हो गया. Vocal anesthesia works always. पूरा आप एक बार क्लीन करके आ जाओ बेटा. ये इम्पोर्टेंट चीज दिखानी है. बस पोट पकड़ो सेंटर वाला. गैस में निकालना बंद करो. डालो. आओ जल्दी आओ. कहीं ना कहीं से फिर छोटा मोटा ब्लड चालू हो जाएगा. जल्दी आ बेटा. सी क्या पूछा. So now you can see what we have done. थोड़ा लाइट के राइट में लेके ना दिखेगा. ठीक है. अभी इधर ही टेक और फोकस कर. You can see that this is a uterosacral cut on this side. Can you appreciate that?
Yes.
This is the uterine artery and vein. This is the artery, that's the vein. दिख रहा है? ये अलग-अलग है. And here is the anterior cut part of the cervix. एक मिनट दिखा रही हूँ. Can you see that? So now what I will do is join the dots just by here to here. This is my line. Okay? So when I said I have to take the uterosacral ke level the uterine, I'm taking it here. Okay? I'm leaving it here. Now Suchi will release the myomuscle. Okay? So I know that this is the ascending part. पकड़ो यहाँ पे. यार पूरा कैमरा क्लीन कर. नहीं टेढ़ा मेढ़ा मत करो. सीधा पकड़ो बस. क्लीन करके आप जल्दी से. या जल्दी से क्लीन कर. और ज़्यादा बीटाडीन से मत सोख कर. If you understand this part, your fear of hysterectomy will go away forever. चलो जल्दी.
Nikita, few small things just I want to know from yours.
Now 1 second, let me just show this. This is one thing which I find the most important thing which people should know. Okay? इसको टेढ़ा मत करो. ऐसा रखो, ठीक है? ऐसा, ठीक है? Now, ureter देखा. किधर है ureter? कैमरा सीधा रखो बेटा. ओके Now, see where your ureter is? Can everybody understand where the ureter is?
Yes, yes.
Clear?
Yeah.
एक बारी पीछे ले लेते हैं इसको और क्लियर हो जाएगा, ठीक है? दिखा ureter? Now, ureter is going here. It is going here. It is going here. It is going here. Now, where is your uterine? This is water under bridge. Can you see the uterine? Water under bridge. Under Abuja. This is your uterine. Can you see that? And this is your ureter going down. दिख रहा है? Now, this uterine, if I take here, okay, I have a chance of a lateral spread. I can go a little bit, one centimeter lateral spread हो सकता है bipolar से, right?
Yes.
So अभी ये मेरा इतना part है. If I go here and take this uterine, okay, that is the transverse part. पकड़ो, मांस को पकड़ो. Stretch मत करना. Whereas if I take it at the level of uterosacral, मेरा uterosacral का level कहाँ है? यहाँ. So I'm taking it here. I'm miles away. Understood? Is everybody in the audience understanding this?
Yes, yes.
Okay. पकड़ो. अभी bipolar दे दो center. So this was the most important part, which is why people get scared of hysterectomy. Okay, they'll damage the ureter. So once you are at the uterosacral and take your uterine here, you will not be able to damage even if you try. Chalo. अबे रुक जाओ. And जितना भी lateral spread हो इधर इतना होएगा ना, it will never go till there. But beyond the uterine, everything comes in more medial. So beyond the uterine, be careful when you're using the bipolar. Okay? Because the lateral spread of harmonic is only 2 millimeter, whereas the lateral spread of bipolar is 1 centimeter. The least lateral spread is unipolar cutting. Okay, and maximum lateral spread is unipolar coagulation. So the least lateral spread is the yellow of the unipolar. Maximum lateral spread is the blue of the unipolar. Bipolar is 1 centimeter, which is more than the harmonic, but less than the blue of the bipolar. रुक जाओ यार. उतना हो गया ये यूट्रस, कुछ नहीं बचा. अरे लेफ्ट फोट बाहर पर. थैंक यू. छोड़ दो. बुलडोग दो या वॉल्सलेट जो भी है आपके पास.
Nikita,
हाँ जी.
how you maintain this time in your peritoneum, like just packing the vagina or?
No. This is ये आप बाहर वाला कैमरा दिखा दो ना, कितनी बार ये क्वेश्चन
Yeah.
सकते हैं. इधर इस लड़की का हाथ दिखा.
From outside?
अरे ये बाहर लड़की. हाँ. Can you see what she's doing?
Yes, yes.
कुछ नहीं. इसने अपना हाथ रखा है वल्वा पे और बंद किया.
And nothing, no gauze piece, nothing. So airtight.
Yeah, it's very easy.
Okay.
यार आपका वल्सलम ठीक नहीं, अच्छा वाला दे दो ना भाई. ये लो. स्पंज. अरे स्पंज वाला स्टिक दे दीजिए प्लीज. एक मिनट उसको नीचे कर. ये ब्लैडर ना ड्रेन नहीं हो रहा. उस साइड से डालो, उस साइड से डालो. यार भाई प्लीज यार, बाद में मत ना. स्पंज वाला स्टिक ना स्पंज वाला गॉस पीस के ऊपर. Cashier, can somebody please answer my mobile? Is it mine or yours, Suchi? learn.
बस 5 मिनट।
मेरा फोन है, आंसर कर दीजिए। कौन है? आंसर कीजिए ना भाई। अरे आंसर करो ना, स्वाइप करो ना। हाँ, मेरा बेटा, उसको बोल दो मैं ऑपरेट कर रही हूँ। I'm operating, I'll call you back, बेटा।
Nikita, just a small thing, how you clean the camera if the meanwhile the vision is hazy and anything like that.
Pooja is cleaning it with Vitaly. या सक्शन का प्रेशर दे दे भाई, तू क्यों सक्शन बंद कर रहा है? Our OT guy doesn't like the sound of suction, तो बीच बीच में बंद कर देता है। सूचो दे दो, काटो, जल्दी करो, सूचो दो भाई, जल्दी कर दो। 15 सेंटीमीटर काटो प्लीज। वर्ल्ड क्लोज करो मैडम। मेरा दिखाओ ये वजाइनल वेसल, मुझे बस करने दो। नीचे चले गए थे ना थोड़ा, इसीलिए। बाइपोलर डालो सेंटर में, जल्दी से फुट पकड़ो। बाइपोलर डालो सेंटर में। तनिषा डोंट स्पीक। सेंटर पोर्ट पकड़ो, टूथ ग्लास पर डालो सेंटर पोर्ट में। राइट अप कर दीजिए सर जी, आप वो सक्शन को ऑन करने दीजिए प्लीज, बंद मत कीजिए और राइट अप कर दीजिए। तनिषा कम या होल्ड दिस। सूचा मेल डालो राइट पोर्ट में, या कर देना राइट अप भाई। किसने काटा ये? किसने काटा? सबने मिलके काटा। राइट अप दो। आप लेफ्ट अप दे रहे हो भाई साहब, दूसरा साइड करो। नहीं, आप लेफ्ट अप दे रहे हो, मुझे राइट अप चाहिए यार। मेरे तरफ कर पेशेंट को। और बस खलास।
Nikita, are you comfortable this time with this table now?
Yeah, very comfortable. Only one OT tech is troubling me.
So one thing can I share you regarding the cleaning of the camera vision?
Yeah, ma'am.
So
garam pani.
You just have a hot water in a flask and keep some gauze pieces so that it doesn't damage your camera. And every time you ask the assistant to open the cap and just put your
yeah. We use that also.
It's a very clear vision.
Yeah.
So sometimes betadine may not clearly visualize.
Yeah, we use that also. Garam pani also, especially in winters in Delhi. We have anti-fog agents also, anti-fog sponges also. सब कुछ मिलता है. But what you are saying is right. Once you see the vision, you should understand whether the vision is not clear from the telescope and छोड़ मेरा हाथ, or from the between the camera and the telescope where it is attached. Because if it gets wet, especially after hysteroscopy when you come for laparoscopy, that time you will need to clear, and I use a hair dryer in my OT to dry that camera at that time. Understood what I'm saying? Between the camera, ये दूसरा एक रास्ता दे दे, बिल्कुल नहीं खुल रहा भाई, ये मेरी लाइन जो है। नोट किया मैं आपके वापस आप लोग है दूसरा। थैंक यू। पोर्ट पीछे करो।
One more trick that I want to share, that you just make a knot outside before starting your vault closer. Big knot so that you can cut through or cross your vault. So it is very easy. You just take it just above sutures. You continuously you start suturing from one side. So make the
blank grass for देदो. Blank grass for देदो please. Okay ma'am. Yeah. Blank grass for दो भाई. Blunt grass for ये नहीं पकड़ रहा. वो जो दूसरा वाला blunt दिया था वही दे दे. हाँ डाल दे. कुछ भी दे दे. जो भी टिश्यू पकड़ा. Yes ma'am, that's also a good tip. We can use that.
So because sometimes the corner is not too much tight, so you make just not outside. It's very much secure dot from starting your corner. There is no smoking or no any thing in this view. If it occurs, then you just give the leak from the opposite port or somewhere else.
We open the what now? We open this thing now. You have your 5 mm ports. You can keep one port open, so all that will come out. Is that what you're asking me, madam? I didn't understand your question.
Actually, my question is sometimes when you cauterize, the whole cavity filled with smoke.
Yeah.
Then how you clear it?
You open one of the ports.
So which one is better?
Or
same side or the opposite side? Just it's fine.
Same side, opposite side, opposite side. The one which is what the 5 mm screw.
Bigger one.
Yeah. And these 5 mm ports also now, I've seen 5 mm hernias also. They've come back later with a 5 mm hernia, especially if there's prolonged surgery. So they're not as innocent as they look. So if you find again, मत बंद करना, मैं तुझे गोली मार दूंगी अगर तूने सक्शन बंद किया. सक्शन बॉय. चल, भाग गया. Now we have a very cute person in the OT who's petrified of the suction now. My suction का pressure बढ़ा दे, please. Please. Please.
He's my assistant. वो करता वही है जिसका मन करता है. हम लोग कुछ भी करते रहो कुछ नहीं सकते.
खाली मुझे इतना सा ये 5 ml ब्लड सक करना है. वो मुझे सक्शन दे रहा ही नहीं है प्रेशर.
Can you demonstrate if the patient having a second degree prolapse or some degree of prolapse, then
अच्छा वो भी anatomy देखनी है.
What prolapse in this case? Yeah, because surgeon definitely do. हम लोग तो करते हैं कि इसका सारा नीचे से भी भाई ACR PFR सब कर दो नहीं तो
नहीं
पेशेंट कम अंदर है टाइम की क्या किया है नीचे तो फिर से आ जाएगा. तो surgeon do like that. But
no, I just showed it in the last case, no ma'am. I showed you the Moskowitz laparoscopic. That is for that only, for to prevent wall prolapse. जिसमें deep POD है, इसका तो ठीक ही लग रहा है. जरूरत नहीं है इसका.
No, the most of the cases nowadays having previous cesarean section, so very few chances like that, laxity of the vagina or that. But the person from the village or anywhere, they definitely having some degree of prolapse.
Ma'am, I also go to Kashmir every month.
Yes.
And I have never seen a single vaginal delivery there. I don't know what is their problem. सबके cesarean, 100% cesarean rate.
I was our places also is hacking so fast.
नहीं but ma'am 100%. I was in shock.
So last time Osama told the same thing. In their countries there is no normal delivery at all.
And Istamocele and all these things which you never even heard of when we were doing PG and everything. Abhi to it's become like the most common thing. Acha. And by popular request, I'll just show the dissection of the space of lenses. So, pakdo.
For all, even in India, in Kashmir, 100% cesarean section.
Toothbrush कर. Right foot में डालो. चल जल्दी कर. Center में harmonic डालो. Left foot में मेरे को एक और दे देगा. पकड़ो ये. तनीषा. क्या करते हैं? ऐसा नहीं होता यार. तो फिर मत पकड़ो. सच्ची तुम पकड़ो. सच्ची पकड़ो. इसके अंदर फिंगर डालो. सेंटर में नीचे डालो. शाबाश. Center में नीचे. Don't go to one side. See, you're going to one side. Where should you be? Center.
Please come on the desk for just a minute.
Blood gas first. Blood gas first. Left foot out. Left foot out. Left foot out. Blood gas first.
And actually, Pusha ma'am also अभी जाना चाहिए. Without taking lunch, you are not allowed. Step down.
Okay. Left foot is out. Okay, so now we're starting the dissection of the spacer Frenzius. My assistant is pulling this part down, and I am just going to start. So you can see the obliterated umbilical from one side to another side. We'll be taking that. Bladder empty हो रहा है ना भाई? यार ये foot दे दो ना please. Allen वाला कहाँ गया यार? Foot दे दो ना. बस. शाबाश. So here I am dissecting the spacer Frenzius. I'm starting here in the center. अंदर जाओ, लाइट के नीचे करो, ऐसा नीचे, टोटली नीचे, एंटीरियर abdominal wall डिसेक्ट हो रही है ना?